Hello, everyone, and welcome to Frontiers in Substance Use Care, Emerging Topics and Evidence, an immersive podcast series sponsored by the Providers Clinical Support System, Medications for Opioid Use Disorder. I'm Kina Thakrar, an addiction medicine and infectious disease physician and longtime member of the IMRSA community. For those new to the podcast, IMRSA is a national organization dedicated to bringing together disciplines and perspectives to strengthen substance use care through collaboration, evidence-based practice, education, and advocacy. This series explores the evolving landscape of substance use and addiction care. In each episode, we highlight emerging research, new clinical challenges, and innovative care models shaping the future of the field. If today's conversation sparks ideas for your own practice, we invite you to explore additional education opportunities and resources available through IMRSA at imrsa.org. With that, let's turn to today's conversation. Substance use during hospitalization is common, yet many healthcare systems lack clear, evidence-based approaches to respond effectively. Too often, punitive responses increase stigma, erode trust, and lead to early discharge, worsening health outcomes. How can hospitals respond in ways that improve safety while supporting recovery? And what practical strategies can care teams use to navigate these complex situations? In today's episode, we explore emerging best practices for responding to in-hospital substance use, including proactive communication, patient-centered policy approaches, and collaborative strategies that support both patients and healthcare teams. Joining us today is our host, Dr. Marlene Martin, Professor of Clinical Medicine at UCSF and Director of the Addiction Care Team at San Francisco General Hospital. Her work focuses on improving systems of care and advancing compassionate, equitable addiction treatment. She is joined by Taylor Basie, a researcher with the Addiction Care Team at San Francisco General Hospital, whose work evaluates patient-centered hospital policies and their impact on patient outcomes, and Dr. Joseph Dunroe, Associate Professor of Medicine at Yale School of Medicine and addiction medicine specialist, whose research focuses on improving care for people with substance use disorders. The presenters report nothing to disclose. Thank you for being part of this conversation. Let's begin.
Thank you, Kina, and welcome everyone. Thanks for joining us. I'm your host, Marlene, and today's episode focuses on in-hospital substance use, a topic that arises often and can cause distress and tension for all those involved. We hope you leave this episode with practical tools to improve your response. We're joined today by Taylor Basie and Dr. Joseph Dunroe, two incredible guests who bring clinical and research expertise to our topic of in-hospital substance use. We're so glad you're here. Taylor,
Thank you for having me.
welcome. And Joe,
Thanks so much. I'm happy to be here.
it's great to have you. To help frame our conversation, I'm going to start by sharing 4 learning objectives. These are the key themes we hope you'll carry with you after listening. 1. Identify reasons people with substance use disorders engage in in-hospital substance use. 2. Understand how stigma contributes to in-hospital substance use and harmful responses. 3. Differentiate between helpful and harmful responses to in-hospital substance use. And 4. Create or improve your healthcare system's in-hospital substance use response protocol. Let's jump in. Based on conversations and research with people who use drugs, we know that in-hospital substance use is common. As we start, listeners, please think about your own practice setting and what your responses, or the responses of those around you are like. What is working and what could be different? Now, Joe, let's come to you. Can you share an example from your hospital where the response to in-hospital substance use did not go well?
Sure. I'll share a case that happened not too long ago that actually involved one of my colleagues on the addiction consult service we have here. I thought it was pretty illustrative of how the response can really go wrong if not handled the right way. So this was a case of a patient who was hospitalized for bacteremia. He was somebody who has opioid use disorder and injection drug use. And my colleague happened to be in the room with him at the time, and his father was there as well. And as they were talking, they noticed that security was gathering outside of his door. And so she asked him, "What's going on?" And he said he didn't know. The father didn't know. So she stepped out to ask for more information. And what she was told was that nursing had found what they thought was drug paraphernalia in the public women's bathroom on the patient floor. And then for that reason, they decided that they were going to do a room search. Security came in. This was the first time that the patient was aware that there were any concerns. The father and security started getting into it a little bit. The father ended up getting kicked out of the hospital as a result. And the security went forward and did the room search. And verbally, were a bit aggressive. Saying to some nurses outside who attempted to come in that they should stay out because the patient was violent, although there was no indication of that, and that if the patient didn't comply, that they would kick him out of the hospital. This was security talking. So after they went through the search, they didn't find anything, and they simply left without giving any sort of follow up to our patient. I think, a couple of things that resulted from that. The father was restricted from coming back into the hospital. That was bad because he was one of the only supports that our patient had. And from our patient's perspective, he was totally caught off guard with this, totally surprised, and ended up leaving the hospital directing his own discharge before he got fully treated for his bacteremia. So really a lot of very unfortunate things resulted from this. And I think it highlights a number of areas that could have gone much differently.
Sounds like it was really traumatic for the patient and their family, just the lack of communication. Joe, could you tell us where things went wrong?
Yeah, I think you kind of hit it on the head with one thing that stands out, which is the communication around this. So the the first thing the patient knew of any concerns at all was security walking into the room and attempting to have a conversation, which wasn't really a conversation; it was really just sort of a one-way directed talk about what the patient needed to do next. I think the other thing that really stood out to me when hearing about this case um, was the reason for doing the room search in the first place, which was finding something that they thought was paraphernalia, which may or may not have been outside of the patient's room, in the women's bathroom where the patient wouldn't be expected to be anyway. It was a male patient. Um, and I think it kind of highlights where stigma plays a role too. And it was known that he had opioid use disorder, and that was the bridge to making the connection that, well, maybe it was our patient that was using in the women's bathroom, which seems pretty soft to me. Um, and then I think the resulting deterioration of the therapeutic alliance there was, um, really stands out as well. The patient left; he didn't get treated. He's been back subsequently, but every time he comes, it's a little bit later in his presentations. He's a little bit sicker when he comes. It stands out in his mind, the situation that happened, and it becomes even more challenging, I think, from this point forward to build trust with this guy.
Unfortunate that he's delaying each presentation and that therapeutic trust is broken. Taylor, you've done research on this very topic and included people with lived experience and healthcare workers. Can you share an example where the response to in-hospital substance use went well?
Sure. I'm thinking of one patient in particular who he disclosed his in-hospital substance use to the addiction care team member at our hospital. They had already had a relationship established. And so the patient felt comfortable disclosing this to the staff member that he had used his own drugs that he brought into the hospital. And I think what stood out in this case was that the staff member um, responded very calmly and said, thank you so much for telling me. Why did you feel like you needed to use your drugs? And the patient said, he was experiencing withdrawals and cravings, and he wanted to be more comfortable in the hospital. And so this addiction consulting member They asked, would you be interested in starting some substance use disorder medications? And the patient was open to it. And then the staff member also asked if they could then involve the primary team to kind of discuss the treatment options, which the patient was open to. And so they had this collaborative conversation between the ACT member, the patient, and the primary team about what medications they could start. And the patient started buprenorphine. He didn't have any additional in-hospital substance use events, and he was able to complete his hospitalization.
I'm glad that the outcome here was different and positive for the patient. Thank you both for giving us these examples. To summarize, I heard best practice responses to in hospital substance use include having these open ended conversations instead of walking on eggshells around this topic. And then two, offering evidence based addiction treatment. And this important point about collaboration between all team members. And when responses do not go well, things that things that contribute to that include stigmatizing and punitive responses that may be driven by bias, poor outcomes for the patient, including self-directed or premature discharges, as we heard here, and then involving security really early on, and then not offering evidence-based treatment. So thank you for highlighting those for us. Now I'd like to go to the topic of in-hospital substance use research, since you both have worked on this topic. Joe, as an addiction medicine clinician and educator, can you tell us what inspired you to do research on this topic?
Yeah, sure. I was, gosh, this must have been 7 or 8 years ago. It was part of a resident-led case conference about a patient who had used drugs while in the hospital, and I was there as the addiction expert. And at one point, they turned to me and asked, "Well, what is the Yale policy on this?" And I didn't know, and so it piqued my curiosity. What is the Yale policy around inpatient substance use? And so I looked, and there was some protocols for the psychiatric units and the emergency departments, but nothing I came across for the inpatient area. And those that did exist in other areas, I didn't find them to be particularly helpful. And so that got me to wonder, well, what about other hospitals? Are protocols and policies something that other places have? And so we did a national survey of hospitals that have an ACGME accredited addiction medicine fellowship program. That we surveyed staff from those places and simply asked the question about, does your hospital have a protocol or policy around in-hospital substance use? If so, would they mind sharing it? If not, do you think that it would be a good idea to have one? And what we found out was that only about 20% of the hospitals surveyed had in-hospital substance use policies and protocols, but the majority of respondents felt like this was something that should have a policy or protocol. And so found that to be very interesting.
Really helpful to have that background. And I imagine that in hospitals without an addiction medicine fellowship, that rate of having a policy might be even lower.
Yeah, I think so. I think that 20% number is probably the best case scenario given the population we surveyed.
Taylor, what about you? Can you share what your team's goal was in looking at the experiences of patients and healthcare workers related to in hospital substance use?
Sure. So for context, our hospital has a patient-centered and hospital substance use policy. It was established in 2021. So in our research, our goal was to understand if this revised policy was being implemented and why or why not. So that was our goal in interviewing patients and staff about their experiences at our hospital.
And what surprised you as you conducted this study?
I would say a couple of things stood out. One is that patients and staff, but particularly nurses, really have the same goal. They want the patients to feel better. They want to help them get better while they're in the hospital and complete their hospitalization. But there seemed to be this disconnect between the two, some maybe like misunderstanding and mistrust that kind of just broke dialogue between the two. So they really have the same goal, but I don't think they fully realize that they have the same goal. And that manifests as them even making the same recommendations for how to respond to in-hospital substance use. So I thought that was really interesting. And kind of on a similar point, there was a disconnect between how simple the solution should be based on what participants said, such as, just pretty basic hospital care and putting protocols in place. So there's a disconnect between how simple the solution should be and how difficult it is to actually put that into practice.
I hear this recurring theme of it coming down to communication, getting everyone on the same page because everyone really wants the best thing.
Yeah, yeah, definitely.
And how did recruitment go?
Recruitment was actually interesting because we wanted to recruit patients at least in both the hospital and in the community, but we found that it was challenging to recruit patients in the hospital. It was difficult to identify patients who use substances in the hospital who were also willing to talk about it while they were in the hospital. I think there was this fear and worry of talking about doing something that wasn't allowed in the setting where they weren't allowed to do it. And patients in the community on the opposite end were extremely willing to talk with me about their experiences. So recruitment of patients was interesting in that way. And I would say similarly for staff, especially nurses, were very, very willing to talk about their experiences. I think this is something that people think about and experience enough where they have experiences that they want to share and they want to improve how things are going. So
So good you recruited from the community. Sounds like that piece is really important.
yes, definitely. I'm really glad that we were able to partner with them.
Really important. And what did you enjoy the most in conducting this study?
Getting back to how willing people were to share their experiences, I think it was really, really nice to just be able to provide a safe space for people to share their experiences, whether they were positive or negative. I think people appreciated the time to get things off their chest, maybe to process and share. And similarly, putting the perspectives of patients and staff like in dialogue with each other. I feel like there's a lot of conversation happening, misunderstanding, but also, like I mentioned before, a lot of overlap. So it was interesting to put those perspectives in dialogue with each other, and in order to identify tangible ways that we can move forward and improve in hospital substance use responses, both in our own hospital and beyond.
Thanks for sharing that. Joe, you also led a Delphi consensus study that involved addiction experts and resulted in recommendations for addressing in hospital substance use. Can you tell us about the study?
Yeah, happy to. So, a Delphi process is a process by which an expert panel creates consensus around recommendations where they don't otherwise exist. So, our expert panel consisted of clinicians that work on an inpatient addiction consult team, as well as people with lived or living experience with substance use who had been hospitalized at a certain point in time. And our group came up with 84 consensus recommendations around in hospital substance use. And those recommendations were classified around things that should be always implemented, sometimes implemented, or never implemented. So it's quite a long list, but I think it speaks to a bit to the nuance of this topic, where people felt there were certain things, certainly some things that should always be done, but there may be times when other actions are appropriate, and there are also certainly things that should never be done.
What were the key takeaways in terms of those things that should always be done?
Well, we have broken it down to things that um, happen at various points during the hospitalization. So things that might happen at the time of admission, things that should happen around the time that in-hospital substance use is suspected. If it's confirmed, what might the next steps be? How should things be documented? What personnel should be involved? What should happen upon discharge, and systems level responses to in-hospital substance use. There's a range of things. I think certainly around the always implement piece. Communication really stood out. Talking about things in advance, having a protocolized way of having these conversations and delivering the care, so it's standardized in our approach. I think some things that really came from the group in terms of always, and there was really almost 100% consensus on, were things like making sure that there's ongoing education around substance use disorders for staff, that recommendations around this topic be implemented such that they strengthen the provider patient relationship. Um, these are some of the concepts that made it to that always list.
And I'm curious about those that people did not reach consensus in.
So there were a number that didn't reach consensus, highlighting, I don't know, maybe thinking about documentation. That was one that stood out to me, where consensus was challenging to reach. I think the reasons have to do with just, the perspective that some of our experts were coming from. As clinicians, we're trained to document. We use our documentation as a way to communicate to other providers moving forward. I think patients with lived and living experience really worry about that as something that can be stigmatizing, a label that's going to follow them. And so that was borne out in the results, and we did not find consensus around much of the questions we had, the proposed recommendations around documentation. The one piece of documentation that did receive consensus for sometimes doing was to, at least if documentation was going to be done, that it be done in a standardized, protocolized, or templated way. I was a little bit surprised at, there were some responses that reached consensus, that when we dove a little bit deeper, we saw that there was a bit of a different opinion between clinicians and people with lived and living experience. Those that there was a difference that still met consensus, they weren't so far off. It was more about clinicians maybe finding that this should always be done, and people with lived and living experiences thinking this should sometimes be done. So it wasn't like they were on opposite ends of the spectrum. But I think when we looked a little bit closer at why those differences might occur, a couple of things stood out. One was that clinicians were seemed to be thinking about feasibility and patient safety, not just for the patient they're caring for, but the patients around them as they were thinking through this. Um, Patients, or our patients with lived and living experience, were really prioritizing autonomy, and minimizing the potential for stigma as a result of recommendations being implemented.
Really helpful to think about those nuances and the differences that people had. Well, thank you both so much for sharing your research expertise, and wonderful to highlight all of these studies that you have done that all included people with lived and living experience. From a national survey to recommend best practices for responding to in hospital substance use, to evaluating whether a hospital's in hospital substance use policy is being implemented, and to this national consensus study. Listeners, I hope that you will check out these studies and learn a little bit more and see if it can be helpful where you practice. Okay, now let's talk about the best practices for responding to in-hospital substance use based on the work that you've done and also based on the studies that are out there. Taylor, where are hospitals falling short?
Um, I think that broadly, which Joe mentioned this, and I agree with, there is an absence of just a baseline substance use disorder education that I think hospitals could be filling that gap. This is what we found, especially, is that this is prevalent in nurses, the lack of substance use disorder education, but also the desire for more. So I think that's something one area that hospitals could improve on. And along the same lines is I think hospitals could make it easier for prescribers and nurses to administer substance use disorder medications, such as establishing order sets just to operationalize a workflow to make it easier for patients to access and receive those medications. And then just in developing any education or protocols, I think that hospitals also could benefit from having more experts, such as addiction consult teams or interdisciplinary champions who are trained in substance use disorders and substance use disorder care on different floors, for example. But I also want to note that even though these are ways that hospitals can improve, it's not entirely on hospitals. There's definitely still gaps in formal education, such as nursing training and med schools. They could, for example, require a unit on substance use disorder care. And there's also just a broader societal stigma towards people who use drugs that needs addressing as well.
Well, I certainly agree with Taylor's points, particularly around the need for more education. I think the other thing I would just add is that um, you know you want your responses to these events to be standardized. That's the way to take bias and stigma out as much as possible. And so, as much as we can encourage hospitals to create policies and protocols around their responses to addressing in-hospital substance use. I think that's quite important. I'd also add that protocols and are equally important for other aspects of care for our patients too, such as starting the right medications for opioid use disorder, for example, or alcohol use disorders, ensuring that we're really delivering the best evidence-based care to our patients. I think that hospitals want their patients to do well. I think that hospitals also want their staff to feel supported and not get burnt out. So I think our ability to highlight cases where things go really well. I think highlighting cases where things don't go well, and the resources that it takes and the effect on patients and staff. I think those are really good starting points. Yeah, I think it's also important to just remember, like, there's a number of voices to sort of raise up here, and so certainly the patient's voice is one. Uh, the physician or APP voice is another. The nursing, but don't forget about how this impacts, social work, security, administrators. Everybody feels it when this really goes wrong, and raising those voices, I think, is an important piece.
Thank you for highlighting the storytelling piece and then also the piece about care experience for the patient, but also for all of the staff members working in the hospital and certainly those involved in these cases around in hospital substance use. Taylor, would you like to add anything here?
Nothing to add, really just echoing what Joe said. I completely agree with the points that he added. And I think that having a standardized approach to this can help support staff and improve patient experiences and care. So it really is when a negative in-hospital substance use response or experience happens, it really does affect everyone involved. And when it is positive for everyone.
I appreciate you both highlighting the importance of education and really taking it a step beyond that to implementation by having all of the experts supporting this response, building education, building capacity. Then I also heard this piece about it's not just on the hospitals, right? And We need national and society guidelines to help provide these resources for how hospitals should also respond. So thank you. Now let's turn the research findings to action with practical, in the moment approaches. Listeners, picture this. You're a busy nurse in the medical surgical unit caring for 4 patients. You have not had any substance use disorder training. You walk into Mr. Z's room and see he is holding a piece of foil and lighter and getting ready to go to the bathroom. You know he has an opioid use disorder on the problem list. What do you do? Now, Joe, let's come to you. You get this page. Your patient is using fentanyl. Come to the bedside. As you're walking over to Mr. Z, you call the nurse who's sent the page and they share, I'm going to call security. Stop giving him methadone and restrict his visitors. What do you do next?
Yeah, good question, good case. I think a few things stand out for me. And there's so many ways that we can look at this. I think one, it'd be great to sort of go back in time here and just sort of think about what led to this point where our patient is walking to the bathroom, presumably to use, possibly, right, with foil and a lighter. Um, has have we thought about the treating the underlying problem? If there's an opioid use disorder, have we thought about pain? If there's a pain process that's going on, are we treating that well? And have we thought about the anxiety of being in the hospital? Has he had a chance to build trusting relationship with somebody working with him in the hospital right now? But we can't always go back in time and sort of see these things in the moment. We've got to, this is a situation we've got to deal with right away. Um, One thing I would say is, this is not the type of case where, we should be troubleshooting it over the phone. This is the one where you got to go see the patient and you got to talk to the nurse, and it needs to be done. It needs to be done in person. And depending on what the timing is, trying to talk to the nurse and hearing his or her perspective on what they saw, what they thought might be going on, is an important place to start understanding the perspective of the staff, and then meeting with the patient and trying to understand the patient's perspective as well. Now, that's really challenging, to walk into a room where you haven't met the person before and ask them to tell you about something that they know carries stigma and weight, and how do you do that? Well, I think as addiction docs, we get pretty good at developing rapport quite quickly, but it's certainly not limited to the realm of the addiction doctor. I think this is a skill that all clinicians need to have. But if there's no trust, it's hard to make connection and figure out what's going on. I probably wouldn't lead with, we're here because, there's a concern about substance use in the hospital. I think I would start by trying to get a sense of how the hospitalization is going for the patient, letting him know that I'm here as an addiction doctor whose role it is to try and address things like withdrawal and treatment for opioid use disorder, if that was what the patient was interested in. Think about what challenges the patients had on this hospitalization, what challenges have they had on past hospitalizations, if there's been any. And then once a bit of rapport has been developed, then bringing up the concerns from nursing and simply doing it in a matter of fact way, and not dancing around it. Simply saying, our nurse said she saw foil and a lighter, and you going into the bathroom with that, and had concerns that you were using drugs in the hospital. I'd like to hear your perspective on that. What are your thoughts? And simply leaving it open ended like that, and allowing the conversation to move forward. And of course, next steps, just depend on how that conversation goes. I do think it's important then to make sure that we follow up with our with our nurse about, how did that conversation go? What are some of the things that we learned in the midst of that conversation? And if we identified some areas that we can maybe improve on the care that's being delivered to the patient, making sure we also follow back up with our patient as well, and not leaving it just as okay, we had the conversation and now we're off to other things. And so that follow-up and piece is quite important.
Thank you for that really nice step-by-step approach that supports both the patient and the healthcare workers involved, in this case, the nurse, without compounding and contributing to more stigma. What about, if you have experienced this, where the response doesn't go as planned, maybe the patient says, they're having strong cravings and nothing that you're giving them is helping, or what if they say they have not been using substances? How do you approach those cases?
Yeah, I think it depends, I think is the answer. But let's take the first case of cravings. Um, I think really trying to get to the bottom of, what are the source of those cravings? Is it that we're under treating the opioid use disorder? I find that to be the case quite often, especially patients who are newly admitted into the hospital. Maybe they weren't coming in treatment seeking, and we have them underdosed on their methadone at this point, trying to control their withdrawal symptoms. Really thinking about, how else can we go about managing their withdrawal? What are some of their other reasons for craving in this moment? Is it anxiety from being in the hospital? Is it feeling a lack of a support network? Really trying to tease apart the root cause will help us to collaboratively come up with answers. um, I think an important piece to this is just remembering that the patient is really the expert here, and they often have the answer, and we just need to listen to what that is, and work within what's feasible in the hospital. But there's often a solution that we can collaboratively come to. I think you also asked about, what if they deny using. Well, I think we always have to be open to the possibility that we're wrong, right? Maybe maybe they weren't using, right? And so, um, uh, here's where I think having a really standardized approach and having clear communication helps. In my experience, the more likely scenario is that, we're not 100% sure. There's a suspicion there, but it's very rare that we see the patient using right in front of us. There's something else that leads to suspicion, and sometimes those suspicions are well founded, and sometimes that they're not well founded. So I think one starting point is just thinking about, where is the suspicion coming from? Is there an objective reason for having this suspicion? Like, I found paraphernalia in the patient's room, or the patient's altered, and I've thought through all the other medical reasons why the patient might be altered in this moment. Um, so a good starting point is there a good foundation for my suspicions? And then two, acknowledging that I might be right or I might be wrong, but we have a process that we're going to go through, because I have this concern. It's the same process I would go through for any patient I was taking care of, who I had this concern for. And these are what the next steps are going to be. And just having that clear line of communication, I think, helps make an uncomfortable situation a little bit less uncomfortable.
Those are really important points, Joe, about highlighting the need for this standardized approach and also leaving room for, there's a lot of cases where people suspect in hospital substance use, and it may not actually be happening, which I know also happens at our hospital. Taylor, what would you like to add here?
Those are all so many good things. Yeah. So echoing everything that Joe just said, I think that communication with the patient and also with the nurse is so important. Hearing nurses out, understanding their perspective and their concerns, I think can really de-escalate situations a lot of times, as well as updating them after the fact of, okay, this is what we discussed. This is the plan. Because I mean, they're going to be the ones most likely administering the medications if that's the route the physician and the patient decide to go. So that line of communication is also really important. And I think when approaching the conversation with the patient, it's really important to emphasize that if this is your hospital's protocol, that you're not going to kick them out. You want them to stay in the hospital. You want them to receive the care that they need and that they want. And so you want to help them feel better to make that possible. I think that that's really important. And then, specifically in the case of if the patient denies in hospital substance use, it's such a good point that just accepting that you may be wrong. And the point is not to figure out if the patient used in the hospital. The point is to figure out if they did or if they have the desire to. Why is that? And what can you do together to prevent that from happening in the future? I think that that is really important, offering those medications. And in the case of if the patient denies in hospital substance use, it's really important to not focus on if they did use or not. The primary focus should be on this is what our hospital says, this is what you can expect if that does happen. And we want to make sure you're comfortable and cared for. So, what can we do now to do that?
Thank you both for those really practical tips on what you can do in the moment. To end this case, the initial page that shared, I'm not giving this patient more methadone, or I'm not giving this patient, you can imagine, more oxycodone. How do you respond to that in real time?
Yeah, I think it really depends. I think having a conversation with the nurse about where they're coming from on this. Sometimes it's from a place of just not knowing. And uh, I personally, I need to check my own biases. I find I often have a bias when I hear things kind of going wrong for my patients. I have a bias that the provider, is leading with stigma. And I have to check that, and I'd rather start from the starting point of we're all trying to do our best to take care of our patients. So I recognize that in me, and so I would try that to have a conversation with the nurse about where are they coming from in this particular case. They may very well be from a place of just not knowing what the evidence-based approach for this is. It may not be from a place of stigma and bias. Um, but then again, it may be, and that will come out often in the conversation that we have. I think if it's coming from a place of just needing more education around, how do we actually treat this and manage that, then education right there tends to be very helpful. I think if it's coming from a place of stigma and bias, then trying to do on the spot education around this stuff doesn't help much in the moment. In my experience, people just kind of dig in on their biases when confronted with them. But I think as much as we can, um, taking some of the choice out of out of the order set is important. So, for example, if it's pain related and we're talking about doing as needed opioids to treat pain, um, I often I rarely do that. I will schedule those medications. I think it takes the opportunity for stigma off the table when you do that. I think when things are on an as needed basis, I think our patients are reluctant to ask because they're worried about the stigma on the other end of the call when they have to make that, and they end up having to wait for the medications a lot of times anyway. And then on the other end, nurses are put in a position where they're wondering, is this really pain or is it something else? So just take it off the table, schedule those medications, and tell your patients it's okay to refuse them if you don't need them. But I think that's a much better approach to pain management and short acting opioids.
And I've often heard, when this has been the response, I'm not giving the opioids. When you dig a little deeper, it's I'm worried they're going to overdose. I'm worried I'm going to oversedate the patient. So it is coming from a place of putting the patient first and trying to do your best, right? And that you can add a little bit of education to help make sure the patient gets standard evidence-based care and the best care for them. And then I really appreciate that tip on scheduling the medications. People do share that too. They're afraid to ask for medications, and you can bypass that. So very great tips. Well, thank you both so much for these practical tips to turn to in the moment. You're both at hospitals that have addiction consult teams. The reality is that most hospitals don't have an addiction consult team. So, what would you be your recommendations for how to make changes come about in these hospitals?
I can start with that. I think that you're absolutely correct. It's the most common scenario is you don't have addiction care consult teams and experts. So I think the first step in that scenario would be finding people anywhere else in the hospital who also want to improve care for people who use drugs, regardless of how much they know. If they just have that desire, you're aligned on that. I think that you can work together to educate each other, learn together, and get aligned on what you can do as a team, what you can feasibly achieve and aim for first, and then you can approach leadership, for example, with a united front. And then also hospitals, I think, should really go back to basics and provide substance use disorder education with all staff, new and current staff, doctors, nurses, social workers, everyone, so that that can set the foundation for a patient-centered in hospital substance use response and protocol. So really starting with that first step, and then you can go into creating a clear non-punitive policy or protocol in partnership with hospital leadership, with addiction experts, if possible, if you can identify them, but also people who use drugs, making sure to include those perspectives in developing that protocol would be super important. I think it's just important to keep in mind that it's going to take time. It's going to take consistent effort. Institutionalizing changes for long-term sustainability will not happen very quickly. So I think it's good to just expect that it'll be a consistent effort at chipping away.
I certainly appreciate that idea around just staying consistent and moving forward in the process definitely takes time. I think the only thing I would add is, I really think most of the things I do as an addiction doc is really feasible for non-specialists. In most cases, I think just as we're internists and generalists, and we need to know, how do we take the best care of a person with a COPD or a person with diabetes. We should have the same expectations of ourselves to provide, really excellent care for patients, for people with substance use disorders. And that means understanding the evidence, being patient centered, respecting patient autonomy. And so I really think, it's nice to have an addiction consult service. I think it's a helpful thing to do, but I think these things can all help happen even in the absence of a pool of addiction specialists within your hospital system.
Yeah, finding addiction experts, champions, people who want to learn, right? And then making it really clear that this is, all hands on deck approach and everyone needs some baseline addiction medicine training so that it doesn't fall on only consult services or ultimately come down to addiction medicine trained experts to address. Because the reality is that in the moment when these are happening or at night when this is happening, that person's not there and you can't depend on just one person. So we should all be able to support this in the hospital setting. So now, as we come to a close, given your experience in this topic, what do we need to study or where do we go from here? Taylor, let's come to you.
Great question. I think there is a lot of great work that has been done so far. There's studies that have spoken with both patients and staff and hospital staff on their experiences with in-hospital substance use, and there's, including Joe's paper, there's papers that have recommendations for best practices. So We definitely are on to a good start. I think the next step is really understanding how those best practices are being implemented. How are they being operationalized? For places who are operationalizing those best practices, how are the policies going? I think things sound great in theory, but it really comes down to how can things be implemented to support staff and also patients in this case. Um, and I think also it'd be helpful to look at in-hospital substance use in diverse settings. I think a lot of studies focus on urban areas, and other studies could look at rural settings, for example, hospitals without addiction consult teams. And lastly, I would say I think that there could be more work looking at how in-hospital substance use might look different, or the responses might look different for different types of people.
Yeah, I think one of the things that the Delphi study highlighted is that there are certain system-wide needs, like the ability of a hospital to provide up-to-date treatment, the ability to educate and train staff in substance use disorders, and it's not new from our study. There's things that we've been talking about for a long time within the addiction world. I'm interested in thinking about, what are the best ways to actually go about doing it. It's seems like an easy thing to say, but I think in practice there are challenges to make sure that everybody's up to speed with substance use care. I think this is a really nuanced topic, and thinking about how to tailor the recommendations for addressing in-hospital substance use to the particular hospital or health system that you happen to be working in is really important. It's definitely not a one size fit all, and the recommendations that enter into your hospital policy might be different from the recommendations that enter into somebody else's policy. It really depends on your hospital, your patient population. And then I think finally, I'd really like to see, you know, more development of effective policies to standardize the approach, not just for in-hospital substance use, but also, just protocols around initiation of treatment, connecting people to care when they leave the hospital, how to manage withdrawal better, how to deal with patient with pain in a more standardized way. I think that's a really important next step for those hospitals that don't have those protocols in place.
Doing what you can to improve care today, right? Building on what you have or what you don't have, and making sure that what you develop is the right fit for your hospital. And then also this piece about we have the evidence, we know what works, and let's move on to implementation because we have lots of guidelines and lots of best practices out there. Now, coming to the last question, as we end, what resources would you like to recommend for our listeners who'd like to develop and or modify their own in-hospital substance use policies?
I can recommend some papers, like we've just alluded to. There are papers out there that have talked to patients and staff about in-hospital substance use. Specifically, the Martin et al. Paper that talks about developing the in-hospital substance use policy at our hospital. And our own policy is actually linked in that paper, so you can find that in the resources. And then there's others. Joe's paper, definitely. There's a Strike et al. Paper from 2020, Lennox et al. 2021, and Alfondre and Geppert 2019. All of those, I think, provide a lot of helpful perspectives and best practices that would be really useful, I think, for people starting to develop their own or improve their own in-hospital substance use responses at their hospitals.
Joe, what would you like to recommend?
Yeah, I mean, I'd certainly recommend, going to the papers that are out there, many of which Taylor mentioned. I think for people really looking to see what is the current evidence, a great starting place is, SAMHSA's treatment improvement protocols, and looking there. But I would also, it's not really a specific resource, but um, as a community of people with an interest in, doing our best to provide the optimal care for people with substance use disorders, it's just reach out and talk to somebody who's creating a policy at their hospital or has a policy. What's going well for them, what didn't work. I think really direct communication around people who have policies in place right now is an important step to developing your own policy or protocol around addressing inpatient in-hospital substance use.
Yes, I completely agree with all of that. And I also will say going directly to another source, which is people who use drugs, and talking to them about their experiences and asking them what would help them, I think is also a good place to start.
What a great note to end on. Thank you both so much for joining us today, Taylor and Joe. We really appreciate your time and expertise. Before we wrap up, I want to highlight a few key takeaways from today's conversation. Prevent and reduce in-hospital substance use by having open, direct, compassionate conversations about your healthcare system's policy or response to in-hospital substance use, and offer evidence-based substance use disorder treatment. Review your healthcare system's response to in-hospital substance use and work with partners across the hospital to improve it. Minimize punitive responses, including involving security in responding to in-hospital substance use. And finally, work with your healthcare system to catalyze culture change. And to our listeners, thank you for spending time with us today. If you found this episode helpful, we encourage you to share it with your colleague or someone in your network. Thank you.
That was Taylor Basie and Dr. Joseph Dunroe in conversation with Dr. Malene Martin on Frontiers in Substance Use Care, Emerging Topics and Evidence. Thank you to Dr. Martin, Taylor, and Dr. Dunroe for sharing your leadership and practical insight. And thank you for listening. We hope you'll join us in 2 weeks for the next episode of Frontiers in Substance Use Care, when we explore how burnout impacts addiction care and what clinicians and healthcare systems can do to protect provider well-being and build more sustainable, supportive care environments. This immersive podcast series is created in partnership with the Providers Clinical Support System, Medications for Opioid Use Disorder. To learn more about PCSS, MOUD, and IMRSA, please visit pcssnow.org and imrsa.org. Technical production is provided by Podpaste. Funding for this initiative was made possible in part by grant number 1H79T1086770 from SAMHSA. The views expressed in this podcast do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names or organizations imply endorsement by the U.S. government. Disclaimer. The information, opinions, and recommendations presented in this podcast are for general informational purposes only and should not be considered medical advice. This podcast is not intending to replace professional medical consultation, diagnosis, or treatment. Any reliance on the information provided in this podcast is at your own discretion. While every effort is made to present accurate and up-to-date information, IMRSA makes no warranty, guarantee, or representation regarding the accuracy or sufficiency of the content featured. The views expressed by guests are their own and do not necessarily reflect the views of IMRSA. Their appearance on this podcast does not imply an endorsement by IMRSA of them, their viewpoints, or any entity they represent. Unless explicitly stated otherwise, IMRSA does not endorse, approve, recommend, or certify any information, product, process, service, or organization mentioned in this podcast. Information from this podcast should not be referenced in any way that implies such approval or endorsement. IMRSA expressly disclaims all liability for any direct, indirect, incidental, or other damages resulting from an individual's use of, reference to, reliance on, or inability to use this podcast or the information presented in it.